All right, so similar theme, different area of the body. It's not necessarily trauma, but I'm going to be talking a little bit about emergency head CT. We do a lot of head CT in our department for patients who present through the emergency, and these are some of the common histories that we're provided with. One is trauma, headache, stroke, and an altered level of consciousness. So what I'm actually going to try to do is present some cases from our institution where patients presented with these histories and just kind of provide a little bit of a pictorial essay of sorts of some of the pathologies that we can see in these settings. Moving on. So we're going to start with trauma. Trauma often results in a traumatic brain injury. The peak incidence of traumatic brain injury is in the 15 to 25-year-old demographic, and males are more often affected than females, usually because they're driving cars at high speeds or ATVs or other mechanical devices. Traumatic brain injury can be classified into 4 different categories. A mild traumatic brain injury usually results in a transient loss of consciousness, usually less than 60 seconds. Oh, I forgot to make a correction here. A moderate degree of traumatic brain injury usually results in a loss of consciousness of greater than 60 seconds, not greater than 60 minutes. And these patients often suffer from a bout of amnesia for up to 24 hours. Severe traumatic brain injury, these patients usually become immediately incapacitated and are unable to follow commands. These patients will often have amnesia for approximately 1 to 7 days post-injury. And in the very severe traumatic brain injuries, these patients also have an immediate loss of consciousness or become immediately incapacitated. However, these patients often die within minutes of their injury. So I'm just going to start with some cases. This is a patient who presented to our emergency department following trauma. You can see that there is a biconvex area of hyperdensity along the inner margin of the right temporal bone, and there's a small blob of gas here within the collection. This is a fairly typical appearance, or it is a classic appearance, I should say, of an epidural hematoma. And this is where blood collects or hemorrhage collects in the potential space between dura and bone. 95% of these injuries are associated with a temporal bone fracture, resulting in laceration of the middle meningeal artery, which is the most common, or vein. Often in the setting of children, it's due to tearing of a venous sinus, and they often don't have a fracture associated with this injury due to the plasticity of their sutures, because their brain can still expand because their sutures aren't fused yet. These patients often present with a lucid interval followed by a decrease in their level of consciousness, and large epidural hematomas are a neurosurgical emergency. As I said, that they are classically biconvex or lenticular, and this is due to the firm adherence of the dura to bone and sutures. These hematomas may cross dural reflections but do not cross sutures, as we can see in this example. And this is just a gross pathology specimen demonstrating the large hematoma in the epidural location. So this is dura, and you can see the brain parenchyma underneath. Our second case is also from our emergency department, and this again shows a hyperdense collection, which is more of a crescent shape along the inner margin of the convexity on the right. And you can also see that there's hyperdense material collecting along the falx as well. There is also some mass effect and edema associated with that, but the main finding is the hyperdense collection. And again, this is a classic appearance for a subdural hematoma, and this is where blood collects between the dura and the arachnoid membrane, and it gives it a crescentric shape, as we can see in this case. Subdural hematomas are the result of a shearing injury or a rotational injury where the brain moves against the veins, which are relatively fixed with the venous sinuses, so you get tearing of these bridging veins. These are not associated with skull fractures, and these blood collections cross sutures but respect dural reflections, as we can see in this case. People who present with subdural hematomas often have a history of closed head injury. In infants, this is usually related to non-accidental trauma, and in the elderly, they're often bilateral. Young patients may have a history of a car accident, and this has a fairly high mortality rate of 35 to 50%, and in some areas I've read it can be between 60 and 90%. And this is due to that shear injury where the brain is moving against some fixed structures in the head. The elderly will often present with this, and they tend to present with kind of a nebulous history, and they often have a history of a fall. They often present delayed, and when we do their CTs, we see a subacute or chronic appearing hemorrhage within in the subdural location, and this is due to the atrophy of the brain. So the brain is separated a little bit from the skull due to atrophy, so they don't present in the acute setting due to mass effect. Again, we have some gross pathology specimens showing the clot underneath the dura, which is reflected back here and above the arachnoid membrane. And this is just another specimen which shows reflection of the dura, and these are these bridging veins that get torn in the setting of trauma. So blood has variable appearances on CT. In the acute setting, it's hyperdense. In the subacute setting, it can be hyper, hypo, or isodense to brain. And in this particular time frame, it can be very difficult to detect. And in that case, MRI may be much more sensitive in actually detecting these subdural collections. Chronic subdural hematomas are hypodense on CT. This CT demonstrates the appearance of an acute on chronic. We can see the low density in a subdural location and some areas of hyperdensity within it, demonstrating the acute bleed on the setting of a chronic bleed. And this just shows you on MRI how it may appear, where this is a sagittal T1 image, which shows the subdural collection, which is bright on T1 in keeping with blood product. So our third case, this patient also has a subdural collection, but this is more of a CSF density, and it's along the frontal convexities bilaterally. This is the appearance of a subdural hygroma. A subdural hygroma is similar to a subdural hematoma, but it's due to the collection of CSF within the subdural space, and this is often due to the traumatic tear of the arachnoid membrane. Instead of seeing blood product, we see fluid which is of CSF density, which does not extend into sulci, and we can often see vessels crossing this density. The differential diagnosis for a low attenuating subdural fluid collection is chronic subdural hematoma, as we've seen, or atrophy with a widened space. However, on this MRI image, we can see that this is from the patient whose CT we just saw, that this collection along the frontal convexities is low in signal intensity on T1, which indicates that there's probably no blood product in there, and it represents CSF. There are other sequences which show that it follows CSF signal intensity as well. Just a little break. And now moving on to headache. In this case, we can see that there is hyperdensity within the suprasellar cistern, and there's prominence of the temporal horns indicating that there is an element of hydrocephalus. So the hyperdensity for the more junior residents is here in the basal cistern. So this is a classic appearance of a subarachnoid hemorrhage where blood collects in the arachnoid space. It can present as in this case where we have hyperdensity within the suprasellar cistern. We can also see it with hyperdensity within the ventricles, within the sulci, and within the fissures. The most common cause of a subarachnoid hemorrhage is aneurysm, but it can also be seen in the multiple other settings such as trauma, AVMs, coagulopathies, extension from interparenchymal hemorrhage, amongst other things. For us, our job when we see subarachnoid hemorrhage is to try to identify the cause. And given that aneurysm is the most common cause, we often do CTAs in order to identify an aneurysm. When we're looking for an aneurysm, we not only want to identify it, we want to find out where it is, how many there are, how big it is, how the rest of the circle of Willis looks, and whether or not there's any evidence of vasospasm secondary to the injury. Just a brief little blurb about aneurysms. The annual rupture rate of intracranial aneurysms is 0.5 to 2%. And in the untreated patients who present with an aneurysm with a bleed, there's a 20% rebleed rate within the first 2 weeks, 30% within 1 month, and 40% within 6 months. So this is a significant finding. This, again, is just a gross pathology specimen to show the correlation with the findings on our CT. We see this hyperdensity on the CT, which correlates with this clot in the same area on the gross pathology. Case number 5 demonstrates hyperdensity within the left thalamus in keeping with an interparenchymal bleed. So obviously there's a differential for an interparenchymal hematoma. Hypertension is the most common cause of interparenchymal hemorrhages, but other things that can cause interparenchymal bleed are tumor, trauma, AVMs, coagulopathies, amyloid angiopathies, amongst the other things on our list. This case is a case of a hypertensive bleed, which in the setting of hypertension, there is damage to the penetrating arteries of the MCA and basilar artery, and therefore that's why we typically get hemorrhages within the region of the basal ganglia. We can also get hemorrhages in the pons, deep gray matter, and cerebellum. They often result in mass effects secondary to the hemorrhage, and when they heal, if the patient survives the insult, they can often heal with a cavity that's left in the area of the hemorrhage. So this is a gross pathology specimen demonstrating this area of bleed within the thalamus. This is in contradistinction to an interparenchymal tumor that is blood. Tumors that bleed often bleed as a result of coagulopathy, either in the setting of leukemia or anticoagulation, but they can also bleed spontaneously due to the underlying tumor. Tumors that typically bleed are the pituitary adenomas, GBMs, oligodendrogliomas, ependymomas, PNETs, and epidermoids or METs. So just a brief slide about differentiating between benign bleeds or hypertensive bleeds versus tumoral bleeds. Things that are not related to tumor, they usually have a simple appearance. On MRI, will demonstrate a complete hemosiderin ring. They rarely demonstrate enhancement. They have a benign evolution. They bleed and then they resolve and heal, and they are often solitary. Versus in the setting of tumor, they often appear slightly more complex on the initial presentation. They have demonstrated a complete hemosiderin ring on MRI. They often demonstrate enhancement. And they don't have this benign evolution where they bleed and then go away. They often have persistent edema and mass effect, and they may be multifocal. Just another little mental break. And stroke. We'll just touch briefly on stroke. This is a CT from our institution which demonstrates some of the early subtle signs of stroke. We have a hyperdense left MCA. There's a subtle loss of the gray-white differentiation and some loss of the sulcal markings. So stroke is defined as an acute episode of neurologic deficit. Oftentimes we do CT in the setting of acute stroke in order to exclude the presence of intracranial hemorrhage and also to exclude the presence of any kind of underlying mass or AVM which may be causing the problem. However, it's important to note that we cannot exclude acute stroke on a negative CT scan in the first 12 hours because we may not be able to see any of the features. And again, we're just showing a pathologic specimen to show you what this actually looks like in the brain. And this area of brown is the area that's been affected by stroke in the MCA territory. Unfortunately, I couldn't find pathology. I guess I could have flipped the picture around to make it look like it went with our case. But this is just an MR, a diffusion-weighted image from our CT case, which shows this abnormal signal within the region of the left MCA. And this you can see very subtly, oftentimes before you see any abnormality on our CT. So as I said, the early signs of stroke are the loss of the gray-white differentiation, or an insular ribbon kind of sign, sulcal effacement, and dense MCA. You can have two different types of edema in the setting of stroke. Cytotoxic edema usually occurs within the first 6 hours, and that's where you get loss of that gray-white differentiation. Vasogenic edema can occur within 12 to 24 hours, and that's the type of edema that spares the cortex, and one that we more commonly see in the setting of tumors and such. So now our final category, altered level of consciousness. Our first case, all of these cases came from our department except for the final one. You can see that there's prominence of the lateral ventricles, the third ventricle, and patency of the fourth ventricle. This is a patient who presents with a communicating hydrocephalus. And a communicating hydrocephalus is the result of obstruction of the extraventricular CSF pathways or the arachnoid granulations. And it can be seen in the setting of meningitis, subarachnoid hemorrhage, can be the result post-surgery, so inflammatory changes post-surgery, or due to venous thrombosis. You often see prominence of the temporal horns, effacement of the sulci, and periventricular edema with dilation of all the ventricles as we've seen in this case. Our next case again shows this dilation of the lateral ventricles, and we can see prominence of our temporal horns. But in the posterior fossa, we see this kind of mass effect where we've had effacement of the fourth ventricle and a very irregular appearance here. When you, this patient subsequently had contrast administered, and we see this large enhancing mass in the posterior fossa. So this is just another example of hydrocephalus, but this is a non-communicating hydrocephalus, which is secondary to obstruction of the ventricles, either at the level of ventricles, the foramina, or at the level of the aqueduct, and resulting in proximal dilation of the ventricles. So the findings are similar to a communicating hydrocephalus. However, in this setting, we see an underlying abnormality causing the obstruction. Again, this is a case of hydrocephalus. We see dilation of our lateral ventricles. However, the subtle finding on this is this area of hyperdensity in the region of the third ventricle. This is a significant finding because it represents a colloid cyst, which is a benign mass which often can be found in the anterior third ventricle of foramen of Monro. It presents as a hyperdensity on non-enhanced CT, and the significance of this is that acute obstruction of the foramen of Monro can lead to rapid onset of hydrocephalus, herniation, and death, and that's a pretty significant outcome. This is another case from our institution with the same pathology. It's a little bit more striking, this hyperdensity here in the region of the third ventricle. However, in this case, the degree of hydrocephalus is a little bit less. And this is just a pathology slide to show you what one of these colloid cysts actually look like. Another case from our institution, on a patient who presented with a decreased level of consciousness, and it was actually probably in the setting of trauma. The major finding on this, there's some effacement of the sulcal markings, but there are these punctate areas of hyperintensity along the gray-white margin. And this is an image of diffuse axonal injury. This is diffuse axonal injury is caused by shearing forces causing axonal disruption, and the shearing is due to the differences in density between the gray matter and white matter, so they move in relation to each other because they have different densities, and this causes these petechial hemorrhages we see along the gray-white junction. It's a severe injury. These patients have an immediate loss of consciousness, and it's the #1 cause of post-traumatic vegetative state. Things that are affected by this are things that are quite stable or are fixed relative to other structures in the brain. So at the gray-white junction, the corpus callosum, brainstem, the superior cerebellar peduncles, and the internal capsule. It's important to note that the initial CT is often normal, and then they develop these petechial hemorrhages over time. And MRI is actually probably more sensitive in detecting early signs of this. This is just a gross pathology specimen of diffuse axonal injury, and you can see these little petechial areas of hemorrhage along the corpus callosum and along the gray-white junction, which indicates this diffuse axonal injury. Another case from our department, this CT examination of the head is strikingly abnormal. There's complete effacement of our sulcal markings. The ventricles are effaced, and the paramesencephalic cisterns are effaced, and there's loss of the gray-white differentiation. So this represents diffuse edema, and this was in the post-arrest setting. Diffuse edema is massive brain swelling and intracranial hypertension. It can be caused by a number of things, including ischemia or anoxic events, as well as trauma. As I said, you get effacement of the sulci and basal cisterns. The hallmark of this is the effacement of the paramesencephalic cisterns, as we've seen in this case, and the loss of the gray-white differentiation. Diffuse edema can also have what is quoted as the white cerebellum sign, where the cerebellum is relatively spared, and that's due to multiple different mechanisms. We have a gross pathology specimen which shows how the gyri get quite edematous, causing the effacement of our sulcal markings. And this is just a brain specimen which shows how edematous the left half of the brain is compared to the right, so you can see the difference between the two. It's also a local case. This patient presented with an altered level of consciousness, and this is an area that's somewhat difficult to assess oftentimes on CT, particularly in the axial plane, because there's a lot of artifact and stuff that can occur in the region of the base of the brain, or the skull base. But the abnormality of note, which is really quite striking on the sagittal image, is this low attenuation within the pons. So this patient represented 5 months later, and you can see how this low attenuation within the pons is quite dramatically more striking. And we have MRR images from this patient which show loss of signal intensity on T1 weighted images, hyperintensity on T2, and low intensity on the FLAIR image. And this is in keeping with central pontine myelinolysis. So central pontine myelinolysis is demyelination without an inflammatory response. It's often due to rapid correction of hyponatremia. And as you can see in our case, the corticospinal tracts are relatively spared, and that's these areas here which are not T2 hyperintense. Those are the corticospinal tracts that have been spared. Extrapontine involvement is also common, and that's due to the osmotic demyelination process. This is just a gross specimen. It's not a great correlate with what we see here, but the myelin should be white, and these areas that are darker are areas that have undergone demyelination secondary to this process. This is our 13th and final case, I should say. This patient also presented with a decreased level of consciousness. This brain is grossly abnormal. There's evidence, obviously, of hydrocephalus with prominence of the temporal horns, but particularly in the posterior fossa, it's relatively hypodense with respect to the rest of the brain parenchyma. And this patient presented following a toxic ingestion, and I think this patient actually presented following an acetaminophen overdose. So toxic ingestions can lead to a number of different, a number of different findings on the CT examination of the brain. They can result in hemorrhage, they can result in ischemic strokes, the posterior reversible encephalopathy syndrome, which we're familiar with, diffuse cerebral edema with the white cerebellum sign, a toxic leukoencephalopathy, which is probably what we're seeing in our case, as well as cerebral atrophy. I just put this in out of interest because there's an article in the Canadian Association of Radiology Journal in 2005 about chasing the dragon. Those of you who probably aren't that familiar with chasing the dragon, because it's kind of street vernacular for heroin use, it's one way of ingesting heroin where they heat it up and then inhale the vapors, and that's called chasing the dragon. But inhalation of heroin vapors has been associated with a toxic leukoencephalopathy, which has a fairly classic appearance, and that's what those two images are going to be. You see hypoattenuation within the posterior limb of the internal capsule, as well as hypoattenuation within the posterior cerebral hemispheres, posterior parietal and cerebellar, parietal and occipital lobes as well, and it's a fairly classic appearance for this toxic leukoencephalopathy. It's a non-ischemic leukoencephalopathy, and it's just something to be aware of. So that was just a little run through. It's far from comprehensive, but it's some of the common things that we can see when we have CTs that come from eMERGE with histories of trauma, headache, stroke, or altered level of consciousness. So I'd just like to thank all the people up in the neuroradiology department for helping with this talk. It's a list of references and then just another little brain break. So that's it.